Good afternoon, everyone. I am Leah Binder. I am the president and CEO of the Leapfrog Group, and I want to welcome you to the Leapfrog webinar on fiduciary oversight in light of mental health access challenges. We're talking today as part of our series on the Consolidated Appropriations Act and employer compliance with its many rules and regulations that are coming your way. Today, we're bringing together some leading CAA, Consolidated Appropriations Act experts to discuss the Mental Health Parity and Addiction Equity Act that requires health plans providing mental health and substance use benefits to provide those benefits in parity with medical and surgical benefits. The Consolidated Appropriations Act imposed audit requirements concerning non-qualified treatment limitations. And to date, no company has received a clean bill of health from the U.S. Department of Labor. So right now, we're at the starting gate for many employers attempting to comply with these new rules and regulations. Employers with multiple third-party administrators are receiving a lot of different analyses from these different TPAs. And employers that separately outsource their pharmacy benefit management, their PBMs, are also receiving an analysis from those PBMs, which may vary from what they heard from those TPAs. So employers, of course, want to comply, but they don't necessarily know how to do so because of really a clear lack of guidance. So today we're going to let these experts weigh in on what you should be doing, on what these rules say, and what are your next steps to protect your company. So first, let's do some housekeeping. We're going to answer as many of your questions as possible, so post them in the chat. We also have a toolkit that is available to you, and it is on Leapfrog's homepage, which is leapfroggroup.org. And then you want to click on employers and purchasers. So there's a section on our homepage which says find resources for, just click on employers and purchasers. And on that page, you'll see the CAA compliance toolkit as well as other resources. Just click on that and it will take you to lots and lots of tools on this issue and many other issues that we've done this series on regarding the Consolidated Appropriations Act. There's also a survey we'd like you to complete at the end that helps us to make sure these webinars are as useful to you as possible. So you'll see that posted as well at the end of today's session. And today's session will be recorded as well and posted later. So let's get started. Today we have Amy Gordon, who is Executive Director of Winston & Strawn, who is an expert on this topic, and she will go through the legal requirements and talk about the experience employers are having with those Department of Labor audits I just said that no one's passed so far. We're also going to hear from James Gelfand. He is president of the ERISA Industry Committee, also himself an attorney who's very familiar with this, with the CAA, also was one of the advocates for it on the Hill when it was first introduced. And then finally, Michael Thompson, president and CEO of the National Alliance of Healthcare Purchaser Coalitions, who always has great wisdom and advice on what to do with the constraints and the regulations and what you're going to hear today. So first, let's get started and start with Amy. Welcome, Amy.
Thank you, Leah. Thank you for that great summary. So what we are doing to date is we have been working with employers that are preparing for those Department of Labor audits that Leah mentioned earlier. And so because the Consolidated Appropriation Act has essentially mandated these audits, the Department of Labor is choosing a number of employers, a number of insurance carriers, a number of third-party administrators, and they are auditing their compliance to make sure the non-qualified treatment limitations with respect to mental health and substance abuse is the same or equivalent to medical surgical. And so this is a pretty difficult exercised for a number of different reasons. And as Leah correctly pointed out, most large employers don't just have one third-party administrator or one insurance company that is administering or insuring their entire program. They have a number of different service providers handling a lot of different aspects of those programs. So, for example, they might have a separate pharmacy benefit manager. They might have carve-out programs like fertility, diabetes, drug savings programs, outsourced medical health administration, EAP, and other types of services. And all of these entities and service providers have to somehow fit together and come to parity with respect to medical, surgical, and mental health and substance abuse. And this is a very, very difficult task. The biggest obstacle that we are seeing is because you have different service providers and they are performing medical management through, different manuals and procedures. It's hard to say everybody is doing exactly the same thing and everybody is, subject to the same rules. So just the fact that you have different entities doing different things causes sort of this disparity in the way that these benefits are being administered. The other issue that we're seeing is that the different service providers, the different third-party administrators, or the different pharmacy benefit managers are actually analyzing the non-qualified treatment limitations differently. Some of them have subcategories, some of them have, it's sort of along the lines of one category, and they're determining, yes or no, do we pass? And so we are seeing, some differences in that respect, and it's causing a little bit of anxiety with respect to our employer clients, our TPA clients, our insurance company clients, because they don't know how the Department of Labor is going to interpret that information and assume whether they're in compliance or not in compliance. And so, again, the reason why employers are going through this exercise now rather than waiting to be audited is because we understand that the Department of Labor has put a very short time frame on an employer's obligation to respond to an audit. And if a lot of these activities are not being done on a proactive basis, it's going to leave that employer or insurer or third-party administrator essentially open to the fact that they might not be in compliance, even though they are, but they just haven't been able to assemble the information quick enough to respond to the department's requests. And in the past, when the department has done audits in general, they've been very flexible about pushing back the time frame on which to comply. But our experience with these audits been less flexible.
I think we are having a little bit of audio problem with your feed, Amy.
Oh, okay.
Okay, you came back.
Okay, great.
So we missed the part about, oh, I think we lost you again.
Sorry. How about now? Can you hear me?
We can hear you. You're frozen.
Can you hear? Okay. Maybe if I turn my video off, sometimes that helps with the audio.
Okay.
And I'll come back. But I guess, the last point I wanted to make was just that employers really do want to comply with these rules, but they're receiving from their different service providers. So I will now pass the baton, and and hopefully when I come back later on, I won't have, you guys will be able to hear me and see me.
That's great. Thank you, Amy. I think all of us are used to the Zoom conundrum of of the day. We're all used to that at this point. So thank you. So let's turn it to James Gelfand.
Hey, you got to go to everybody else in the office and tell them to turn off Netflix and YouTube because you got to do Zoom. And by the way, I'm glad this is a virtual presentation, Leah, because had I known that you were going to introduce me as somebody who advocated for these mental health parity requirements in the CAA, I would have feared being chased out of the room with tar and feathers. Although I will say it was a compromise, right? It was better than the alternatives that we were looking at in Congress at the time. So, I think I'd like to just start by, saying mental health parity just continues to be a challenge for employers. It's due to the complexity of the law and the dearth of guidance. And it's not because of negligence or ill intentions by employers. We're right now waiting for a major rule to come out from the federal agencies. And I don't think anybody quite knows what's going to be in it. Will they provide the illustrative examples of acceptable non-quantitative treatment limitations that they have been told time and again by Congress to do? Maybe. We don't know if they're going to try to expand the definition of parity. Are they going to include things like network adequacy or reimbursement rates? Will employers be put on notice about new kinds of comparisons that the agencies are going to start doing? Things like looking at claims denial rates across the medical plan versus the behavioral health benefit, or looking at the provider directory accuracy or credentialing issues for which providers are allowed to perform which services within a plan. Again, we just don't know. But meanwhile, outside of the government, you've got a lot of litigation that's going on in this space. So in one case that we've been watching pretty closely, a plan sponsor is accused of violating parity rules by applying different quality metrics to inpatient behavioral health facilities than they applied to hospice care. Now, when we look at that, that's a total apples to oranges comparison, but you don't know what the courts are going to decide. And with the agencies having not put out a rule that specifically explains how to do some of these things, the courts get to make a lot of those decisions. In another case that we've been looking at, an employer is under fire for refusing to cover wilderness therapy. You got to remember that battles continue to rage over treatments that most employers think are experimental or are of questionable quality. The other one that I'm constantly hearing about is equine therapy, right? So you're gonna have your health plan pay for people to go camping or pay for them to go visit the petting zoo. Like, that's an open question right now, and the courts may impose rules there. And of course, there are still a number of cases focused on issues like assignment of benefits, which these out-of-network providers, they try to use this as a way to force employers to pay for their billed charges, or the definitions of a behavioral health within a behavioral health benefit, like in the California WIT case, where a judge ruled that your benefits plan needs to align with recommendations from the lobbying groups that represent mental health providers, right? So all of that's happening completely outside of the rulemakings, and employers are kind of left in a conundrum of, we don't know what we're supposed to be doing to do this right. We also continue to hear from employers that their vendors are not all being quite as helpful as they could be in terms of CAA compliance. Numerous employers have told Eric that when they have asked their vendors for parity analyses, the insurance company or the PBM will come back to them and say, well, why? Why do you need this right now? We're very busy. We'll provide you with the analyses when you're getting audited or when a patient, initiates action against you. But until then, we don't have time to do this for you. Well, guess what? That is completely unacceptable under CAA. CAA requires us to have those analyses on hand. And yeah, part of the reason why you need to have it on hand is so that if the government asks, you can give it to them. And as I think Amy said, they're pissed that they asked for a lot of these analyses and the employers said, well, we don't have it. That was not an acceptable response from the employers. But that's not the only reason why you need them on hand. You also need to actually be looking at them, right? You need to actually ensure that the plans that you're purchasing, that your vendors are running on your behalf, are actually meeting your fiduciary duties, and that they're actually properly following and documenting how they are properly following parity rules. So I do think that this is getting better over time. And I think, Amy mentioned that as time goes on, more of the vendors are actually putting these analyses on paper And if they have it on paper, they're more likely to offer it to the employer on whose behalf they're running these plans. So, we do think that the slow start cost us, though, in numerous ways, and it's damaged our position with the Department of Labor, and it's damaged our position in Congress. It's fueled the fire for those who want to impose penalties, who want to weaponize the federal government on parity issues, and otherwise make things worse for plan sponsors and administrators. So what comes next is anyone's guess. We expect that there's an omnibus bill that'll probably be introduced in the next couple of days, and it'll probably have some mental health provisions. But this debate is extremely likely to go into next year in the 118th Congress, and employers are going to need to expect to be on the defensive on these issues. Now, it's a little bit ironic, of course, since virtually all employer health plans do offer robust mental health benefits on a voluntary basis, right? It's a voluntary system, yet employers often find ourselves under fire from the government and from the health industry and from the patient groups because they essentially want us to write a blank check. But of course, you all know that writing a blank check isn't actually being generous, it's being irresponsible. We're ERISA fiduciaries. As the CAA reminded us numerous times, it's our job to ensure value for the plan beneficiaries. And sometimes that means that employers have to be the bad guys. Sometimes that means we have to say no, we have to impose limits, we have to impose things like medical management that the patients hate and the doctors hate, but that is necessary to drive value and to control costs. Ultimately, while the employer may be cutting the checks, the money belongs to the patients, right? That's what ERISA is all about. The money belongs to the employees and to their families. It's part of their compensations, and we're just trustees of that money. So it's a kind of a complicated arrangement. There's a push and pull to it. And Eric knows that our member companies and the employer community writ large, they're doing their best to navigate these challenges. We're lobbying for better quality data. We're trying to address the behavioral health workforce shortages. We're trying to cut down on some of the red tape and allow more flexibility and innovation. And we're also trying to align state and federal rules related to telehealth, because we think that's a key part of the solution on mental and behavioral health. But as the mental health parity landscape continues to evolve, we're going to continue to advocate on employers' behalf. So, I appreciate the opportunity to participate today, and I'm of course happy to take any questions. And I think now I'll pass it over to Mike Thompson to give his perspective.
Yeah, and I'll probably take a somewhat different angle on this. First of all, I'm the non-lawyer here talking about parity, and so take everything I say with a grain of salt. But I kind of come at this with a common man's view of what does it mean to be a fiduciary, and how does one deal with what is inherently a real problem under our plans today. And the real problem isn't the minutia that is being brought to light around these things here and there. It's really fundamentally that we are offering mental health benefits through the plans, and oftentimes it's illusory in terms of how people access the plans themselves. All of this noise around parity isn't being driven because people are really anxious about these minutia on the side. It's really being driven by the fact that people are aware that the networks are often inadequate, or if they exist, they are difficult to access for new patients. And the term ghost networks now is getting a life of its own in Congress, and really punitive legislation is being proposed in Congress around these issues. So I think at its core, I totally appreciate that the enforcement of the Parity Act is almost impossible, both for the regulators and for the plans and the plan sponsors. That there's so many moving parts when you get into non-qualified treatment limits. If you look hard enough, we're all out of compliance at the end of the day. I don't think that's what's driving the noise. What's driving the noise is access. And if you look at the title of this webinar, is what is my fiduciary responsibility in light of access problems, right? Well, suppose there was no parity law. And suppose that you put a bunch of providers in your directories and you advertise to your employees that they had access to a benefit that may be a mirage for many people, that they have a hard time getting at. Do you have a responsibility as fiduciary to take action on that? Clearly, most employers have in fact taken action. They've overlaid carve-out benefits. They have paid for out-of-network, in-network. There's lots of activities that employers are trying to overcome the access issue. The reality is most of those overlay activities probably still wouldn't cause you to be in compliance with parity at its core. And so you're still vulnerable if the underlying plan does not have a network that is accessible. I think most people know that the National Alliance has been a very strong advocate in improving access and quality in the mental health field. We are one of the founding members of the Path Forward for Mental Health and Substance Use, and we consider this probably the biggest crisis in benefits today. I think most employers, part of the reason there's so much interest in this webcast is most employers actually identify this as one of their biggest issues, and they're trying to do something about it. So again, I don't think it's for lack of interest or lack of concern, but I don't think the right thing is to play defense on it. I think it's to play offense, and that's to work with your service providers to ensure that they are acting on it. What's kind of odd for us sometimes is we hear significant progress being made through the plans, and then we hear from the employers that the problems are still there. And then we hear from the providers that nobody's asking them to join networks. And if they try to join a network, it's really hard to do so. And I'm like, how do you reconcile all that? And how do we actually, as fiduciaries, own the issue and expect from our service providers that we don't offer a benefit that is not real for our employees? And at the end of the day, I think that's what being a fiduciary is. Don't stop being the advocate you need to be from a legal standpoint. Again, I'm not the lawyer. Yeah, have a paper trail there. But at the end of the day, I think the issue is having the access, not complying with parity, because that's where we need to double down. So I'll stop there. This is a very complex issue. I don't begrudge any plan sponsor for trying to figure out how to meet the law here. We advocate very strongly. Stop putting this on the plan sponsors. Look to the plans as your intermediaries here. But of course, as a self-insured employer, you are a plan, and unfortunately, the gun's being pointed at you too. And I think we don't want that gun to be pointed at you. But let's bring it back to the basic fiduciary responsibility to advocate for how your benefits are being provided to your employees and their families. And this is a very serious issue that should not be minimized based on things in the market. I saw that there was a question from Candace on, if you provide travel benefits for abortion, does that violate mental health parity? It probably does, right? Anything you provide on the medical side, you got to provide on the mental health side. You can provide more on the mental health side, but you can't provide less. So, and a lot of people are providing more on the mental health side. That doesn't solve the parity issue if there's anywhere you're providing less. So I'll turn this over to you, Leah, and we'll have a conversation.
Leah, you're on mute.
The mantra of the age, you're on mute. So I think Michael brings up a really important point about fiduciary responsibility. And so James, just to reassure you, I shouldn't have said that I thought you were a major advocate for these regulations per se. I recognize you are certainly not. What you have been an advocate for is the notion of giving employers the tools they need in terms of legal protections and legal responsibilities to be good fiduciaries. So, I mean, that is the real essence of what happened with the Consolidated Appropriations Act, is it gave employers a lot more power, tools, leverage to get done what they want to get done, to be good stewards of employee health benefits. So let me ask you the question that Michael just posed. How do employers best act as fiduciaries in this environment of a lot of unknowns. What's the first step for an employer who wants to do the right thing?
Maybe I can start and then Amy can add
Yeah.
on to it. I think that what's really important for employers, like an employer cannot build a network of mental health providers. You have to rely on vendors to help you with this stuff. An employer is probably not going to be putting together what are the limitations within a plan and how many days is an individual going to be allowed to go to an inpatient facility and which drugs are going to be on which tier of the formulary, right? You're going to have to rely on your vendors to do that. But the question is, can you simply just take what they give you and assume that you're good to go? Even if they say, you know, we're putting our stamp on this, we certify that we are within the rules. That's really just not good enough. And I think that what the CAA recognized is that that is how things had been working and that they wanted to make a change. So there's supposed to be a host of new information that is now available to employers, right? So you are able to get the plans to send you all of the information about how did they come to these decisions, right? How do they justify the limitations that you have in your plan? And you're supposed to look at them and you're supposed to go back and ask questions, right? It should probably be an annual thing where you review to make sure that not only do you have all the paperwork, but you've read it and that you understand it and that it makes sense to you. There are other parts of the CAA that also play into this. For instance, I was thinking just earlier about Section 201 that bans gag clauses, right? So previously, your vendors might have said to you, listen, we've got a network, but we're not going to tell you exactly how much we're paying who or what arrangements we have with which providers. And, you know, we'd love to, but we signed an agreement with the providers, so we can't do that. Well, that's now illegal. So you now have access to that data, or at least you should have access to that data. But guess what? It therefore comes with responsibility. You have access to it. You have to actually look at it, right? And if you look at it and you find, wow, it doesn't seem like my vendors are actually trying to build a powerful network. Now, you know, to one of Mike's points, I would say you always hear from the providers, oh, we desperately want to be in all the insurance networks, but those big bad insurance companies won't let us. And we heard that throughout the surprise billing debate. It was obviously a lie during the surprise billing debate. Maybe it's not a lie as much in the mental health space, but there's different actors here, and you've got to start basically taking pieces off the table. You've got to take pieces off the board, eliminating possibilities of where the breakdown is taking place. And employers now have the tools to take the insurers and the PBMs off the table because you have access to all the data. You can read through it, you can check them, you can make demands that you couldn't do 2 or 3 years ago because you didn't have the information that you needed to do that.
So Amy, what are your thoughts? What happens when an employer has TPAs and PBMs all giving them different information? Should they have confidence that they can do as James says and actually read all this stuff and know the right answers?
So I think it's a good question. Most employers are not in the medical industry. Most employers are widget manufacturers, and they operate in other areas where their expertise is not with healthcare, which is why they are hiring these third parties to deliver these benefits to their participants. So I think it's a slippery slope to essentially say they have this fiduciary obligation to, one, make sure the network is robust, or to make sure that these providers are substantively equal in the form of qualifications as, you know, their heart surgeons and their knee surgeons. So again, I think most employers are relying on these service providers to do this for them. I mean, they're paying them, they are asking them to do what they can to essentially beef up the network, provide good services. And, you know, so they're really not in a position to analyze the data, I think, in the way that it would, you know, in an ideal world, they would be able to. But to be able to analyze the data and say, wait a minute, we've got deficiencies here, or wait a minute, we should probably try to attract more providers. I worry that if this is a fiduciary obligation on plan sponsors and employers, that it's almost like a bar that's just too high to hurdle. You know, I mean, it just like this could become a full-time job. You can't operate a business efficiently if you're also being tasked with the responsibility to make sure everything in your healthcare plan is operating, through the perfect lens that the regulators, I think, are looking for. And I'll stop there.
Well, Michael, what if you disagree with what you see from, even if they all agree, all the plans agree with each other, but you disagree, what do you do?
Well, here's what's funny is it's easy to discount that the employers don't know what they're talking about. They don't really, they're not experts in this. You don't understand what it means to get a network. We don't know what it is. Employers and plan sponsors are in a very unique position. Many people have heard me use this statement in the past, where a benefit person once told me, Mike, what you don't understand is I live in the variation. And it's always stuck with me that the people who run benefits for major organizations don't get exposed to when things go right, but they get totally exposed to when things go wrong. And the reason this is so high on their priority list is it's one of their biggest pain points, because real employees and real families are having serious issues not having access to networks that they are offering as an employer, as a plan sponsor. So the idea that they don't know enough, no, they actually know quite a bit about how problematic it is. And if they are not advocates, there's nobody else advocating, because we've been advocating for a long time, and they have to be those advocates. I think that is a fiduciary responsibility. And when they hear the stories from the plans, if it doesn't resonate with what their reality is, because they see the variation, they see the problems, then they have to keep pushing to keep moving forward. So I don't discount the sophistication of employers in this space. In fact, I think they see it better than the plans do themselves. And because they're experiencing it with real life situations, I won't say daily, but enough that this is not a small problem. It's one of their top problems. And so they have to advocate as fiduciaries, my view, not a legal view. I'm not looking to take people to court, but I am looking at it and saying, if not plan sponsors, who? How is this ever going to get the attention it needs to pull it over the corner? I do think some things are getting better. Telehealth is a good example of that. It really kind of opened up an awful lot more people participating in the system. It's not that everything is getting worse. And I do think we have to be open-minded as to how we solve the issues. But I don't think we should take the easy out and say, oh, I got a report from the plans and everything's okay. And by the way, that report from the plans typically doesn't apply to you, because you do have these other vendors that are overlaying, and those two don't even talk. So how would you ever know that you're in compliance with parity? So, but anyways, I'm going to advocate a little bit differently.
We have a question about telehealth, but before I get to that, I just want to ask both Amy and James the question of, what does a plan sponsor do, given that they are fiduciaries? What do they do to advocate for what they need when all roads seem blocked? Let me start with you, Amy.
Well, I think just to go back for a second, what Michael was saying, and then Leah, definitely I'll respond. I mean, when you have a prudent service provider, there are a number of different categories that you evaluate that service provider. Not saying that the mental health network is not one of those categories, but what I'm saying is it's only one of the categories. So if you have a service provider that has a wonderful provider network when it comes to mental health, but they are abysmal at paying claims, and you have a bunch of participants complaining that they're not getting their claims paid, that's as much of a problem as it is having this robust network. Or if you have a service provider that allows every provider, no matter the quality or no matter, what their, what they bring to the table. If you say it's sort of a every willing provider kind of a network, that's wonderful. But as James pointed out, you also have a fiduciary duty with respect to keeping the costs down. So there are a lot of different competing interests here that plan sponsors are struggling with to be able to essentially do their fiduciary job as a whole. So just to take that point and then to move it to what you were asking, which is if you are finding that they have these issues or that they're obviously getting a lot of complaints that people are not being provided access to the necessary care and service providers that they need, what is the duty on the part of the employer plan sponsor? I mean, the duty is like every other deficiency in the services that they're receiving. They have an obligation to go to that service provider and say, hey, we're getting a lot of complaints about an insufficient network or insufficient quality service providers, and we need you, service provider, to step it up and get better providers in your network and to have more availability when individuals need that care. But we just can't look at that one thing in a vacuum.
So, I know ERISA and CAA are very clear on the fact that process is really, really important, right? You don't actually always have to prove that you got to the end result and everything's perfect. You obviously that's not going to be the case for everyone right away. But the idea is you have to demonstrate that you went through the right process. So that's why I'm trying to kind of really hone us into, well, what process should an employer or a plan sponsor put in place right now to protect themselves, or at least to try to do their best, given this extremely unclear environment. So I turn that to James.
Well, and Leah, I think it would help to make sure that everybody is clear on the fact that ERISA doesn't imagine that an employer knows how to do everything, right? A lot of ERISA is all about vendor management. So what is prudent vendor management? And to speak to that, actually, there's a question in the chat over here. It says, well, can I just get my plan to sign that by X date I'll be in compliance with mental health parity? No, like what CAA is all about is that you can't just take anybody's word for it, is that you actually have to check for it. And if you are not, if you as an employer are not an expert on networks and mental health parity and parity analyses, et cetera, then you need to hire somebody who is disinterested that can look at it for you. So, Amy's firm or an auditing firm or just a boutique expertise firm that just works on this, then farm it out, right? But the idea is that there has to be a trust but verify element here that's part of that.
All right, trust but verify. That truly is the fiduciary. That's really the central piece of anything fiduciary responsibility, for sure. Michael, did you want to add anything to this conversation? Because I know this is this issue of what employers should be doing to trust.
I think it's very fair. The truth's in the middle here, right? The plan sponsor, when we talk to regulators, we say you can't hold the plan sponsors accountable for something they just can't do this. I mean, they're not going to be, maybe some very large employers can contract with its own network because they can't get the network through their. But at the end of the day, it's a product, right? It's a product that's supposed to have a network. The network is supposed to have access, and if that product is defective, as a vendor manager, you require it to be improved. And if it can't be improved, it can be improved. The question is at what cost and at what pain, right? And to Amy's point, nobody's saying give them a blank check, but at the end of the day, why would you have a network you can't get access to? I don't get that. I don't get that. And then if you don't have a network you can get access to, then you don't have a network. You don't have a network. So you have a flawed product. So what would you do with any other part of your supply chain if you had a flawed product? You would insist. Now, what we do is we do workarounds, and then we'll just pay out of network, or pay in network out of network, or we'll go get another vendor that actually has a network, right? And and all of that. The parity stuff, I think, is complicating all of this. The plans are playing defense on parity. They're getting fined, they're getting penalized, and now the employers potentially could as well. But at the end of the day, as a fiduciary, you're buying a product that should have services. I do think, and this is where I'm going to kind of lean the other way. I'm trying to be open-minded about how do we solve the problem, because there are shortages of providers, and we need to figure that out. And we need to be open-minded about not so much, does it work exactly the way it was written up, but actually that we actually have a solution across the spectrum of mental health needs for our employees and their families through our providers. And if they have a good plan, but the plan sponsor is actually one of the most qualified entities to make that judgment, because they know whether their employees and their families are having problems. And if they're having problems, you got to keep advocating. Don't take this piece of paper as the answer if it's not working in reality. In reality, it should work, just like most of what we do does, but a lot of times this doesn't. So I'm going to bring it back to what has been the experience of plan sponsors, employees and their families. And until that is working, I don't think, I'm going to put the parity discussion on the side. Again, I'm not the lawyer here. I'm thinking about the product, and the product is what you're representing to your employees and their families. And there's nothing more serious than when your son or daughter or your wife or yourself can't get access to mental health care on a reasonable basis. I mean, this is as critical as anything you're offering, is in my view.
And I think it's important to recognize that. I think what you're really emphasizing, Michael, is that plan sponsors and patients and families have an expertise in this, and we need to have some competence in our own expertise as people who experience what this system is really like. And so I think when you feel confidence in your own expertise, it's a little bit easier to go to United Health and say, no, this is not working. This is not fulfilling my fiduciary obligation. It's a hard thing for plan sponsors to do, but recognize you do have an expertise. You are recognizing some issues when you hear from your own employees. You are seeing something that others do not see, and you need to articulate that. So,
and Leah, if I could jump in on that, and two things to say. One is that this is a bigger problem than a benefits problem. And there was a question in the chat that asked, is the real problem a shortage of providers? That workforce is a huge part of this problem. And that workforce problem creates other problems as well, right? And so there was another question in the chat about, well, what about reimbursement and how much do we have to pay the doctors? And the truth of the matter is, I personally don't think there is any amount of dollars per hour that you can pay a psychiatrist to get him to move from Los Angeles to Peoria. I just don't think that is a real thing that happens. It's not. And even though the APA may be arguing that on Capitol Hill, it's just not realistic. And so this is a two-way street, and we're not going to solve this problem just by yelling at the employers and the insurance companies even. The providers do have to have some personal responsibility there. I also wanted to point out a comment from Elizabeth Mitchell at the Purchaser Business Group on Health. She said that they looked at the data from 30 different plans, employer plans, and found that they were all failing in certain aspects. What's important to note is that PBGH members many of them are ERIC members, or they're very similar to ERIC members. These are the most sophisticated plan sponsors in the country. Okay, and if they are experiencing these kinds of failures from their vendors, it's likely that everybody is, right? And the reason that we can now know some of this information is because of CAA and because of the information flow that's starting to happen. And so hopefully this information flow starts to lead to action that improves care for the beneficiaries and also protects the employer by providing us with confidence that we are within compliance and are not going to get sued or not going to get attacked by the federal government.
well, you mentioned the issue of distance from the workforce, or the distribution, I guess, of the workforce across the country, and the fact that we do have a question about rural health. What happens if, let's see, I can find it, but there was a question about what happens if there's just a real shortage. Can you find a way to, for telehealth to be considered compliant? Amy, do you want to take that on?
So telehealth is, it has definitely worked as a stopgap for many different ailments and illnesses, especially when a provider is not available within close proximity. It has solved the problems of people who don't have cars and don't have transportation. But where we're still falling behind on telehealth is the licensing, and also in certain states what a telehealth provider can do and can't do. So I definitely think that telehealth could go a long way in helping with this mental health parity issue if regulators could be a little bit more open-minded with respect to telehealth, and they weren't so strict with respect to what certain providers can do. I mean, there's issues where a telehealth provider might be in one state and providing care to somebody in a different state. There are also some states that say that unless you have a face-to-face meeting with that provider, then that provider can't prescribe prescription drugs. So I still think there is a lot of lag with respect to legislation and licensing and abilities, but I definitely think telehealth could go a long way if we just let it.
What do you think, James? I know that Eric has been very active in promoting the use of telehealth in all areas, medical, surgical, as well as behavioral health.
Yeah, I mean, it takes a very long time to train a doctor. Right. So we could start today. We could quadruple the investment that we currently make in graduate medical education. And it's still going to take many years before those doctors are actually out there practicing. Telehealth is something we could do right now. Right. But there are laws that actually prevent it. And Amy hit on probably the two most important. Right. Number one is we don't have interstate licensure. There are interstate compacts. It's different for nurses than it is for behavioral health providers, and for the PsyPact that governs psychologists and psychiatrists than it is for the IML. Is it IMLC, the one that's for primary care too? Like, there is no easy way to do it right now. And the federal government so far refuses to take action because the state provider cartels don't want competition from out of state. So you have this crazy thing going on where a state might have a shortage of psychiatrists, right? But the psychiatrists that are actually in that state are making big bucks because of that shortage. In fact, they're making so much money, they don't even need to accept insurance, right? Why deal with the insurance companies? Because if you agree to an in-network contract, not only do you have to start following their rules and dealing with their computer systems, but you can't balance bill the patient. Whereas if you are outside of network, you can bill anything you want, or maybe you just only accept cash. Like, there's a huge advantage to maintaining that shortage. And that's one of the things that's causing one of the biggest problems is bad actors in the system that are making a lot of money off of this. And part of that goes into another thing Amy mentioned, which is scope of practice, right? Certain doctors aren't allowed to do certain things or to treat certain patients or to prescribe medications, et cetera, in various states. It's not based upon the skills that those providers have. It's based upon these cartels that make money by requiring those services to be funneled through them. And so until we can knock down some of that, even telehealth is going to be somewhat limited in what it can do. Now, we have, I think, gone state by state and changed most of the rules. So for instance, the originating site rule, where they would say that in order to use telehealth in a certain state, you have to go to a cyber cafe, or the rules related to which provider can see which doctor, where some of the states still say you can only do telehealth with your doctor, right? Which makes it impossible to use, telehealth services like Teladoc or Doctors on Demand. It literally doesn't work if you can only do it with the doctor who already has you as a patient, right? The whole point is to try to connect people who don't have mental health doctors with doctors. And some of these states literally say you can only connect people who already have a doctor. So there's all these crazy rules. They're almost all devised by state medical boards or state provider societies. And the goal of these rules is literally to cut people off from access to care. But then what they do is they go to Capitol Hill and they say the problem is insurance companies. The problem is employers. They are money grubbers. They don't want to pay what they need to pay to get doctors. And so you have this vicious battle going on with patients trapped in the middle. And these are patients who actually need to see a doctor and they can't. And that's getting, I think, a lot of times lost in these conversations.
And I would add that's also nurse practitioners and physician assistants that are part of that provider equation. And I've appreciated that Eric, ERISA Industry Committee has been actually a proponent around this issue for many years, long before we had, even before mental health parity that was part of the CAA, and all of the fiduciary issues have emerged in the past few years. You've been an advocate at the state level included, as well as the federal level, and really pushing for more access. So I appreciate that very much. I think that's certainly made a difference where we are now. At least there's more options than we had 5 or 10 years ago for plan sponsors to be able to offer some level of access that is somewhat close to parity, let's say. We do have a specific question. I'm turning to some of the questions now. There's a question: is requiring mental health substance abuse treatment to be referred, is there requiring a gatekeeper, like a PCP or gatekeeper? Is that a violation of parity? Maybe Amy, do you have
Yes,
any-
I can answer that. If that gatekeeper only applies to mental health and substance abuse and not to medical surgical, that is absolutely a violation of the non-qualified treatment limitations.
Okay,
If
but
it
it's all
applied,
of-
I'm sorry, yes, if it applied equally to all, then it would not be a violation of the non-qualified treatment limitations.
Okay. Let's see, another question. Okay, let's go back to the original question about
The abortion?
yeah, the abortion question. We touched on that a little bit, but is that a violation if you offer transportation to abortion services, but is that going to put you in some kind of jeopardy in terms of your mental health parity?
So we think that that is definitely an open issue. Nobody has actually come out and said having a travel benefit that only applies to abortion would be a violation of the mental health parity. I think it could be, because obviously you're providing better access for one type of care versus another. So in being generous and applying these travel reimbursements to abortion, but not to other benefits that might be equally as difficult to access, that I think you definitely could have an issue with respect to that. But we have not seen the department come out definitively and say it's a problem. The EEOC has started kind of sniffing around this area, and they have actually said that they think that if you are providing more favorable benefits for abortion care than you are for other benefits, then you could be essentially discriminating in favor of individuals who either need an abortion, or or women versus men. But so I think this is definitely a hot issue, and I think we're going to see more of this in the near future.
Okay, thank you. Michael, when James was talking earlier about some of the laws in different states, or some of the restrictions in different states that do make it very difficult to have things like telehealth work, or have full access to all the providers who potentially could offer good care. It sounds like there's some advocacy that we need from employers. Can you speak to that? I think that's something that I know the National Alliance has been extremely active on at the national level, as well as the regional and local levels.
Yeah, no, I totally agree with James. This is, we have to keep our eye on the ball. The eye on the ball is not parity. I want to keep saying it is not parity. The eye on the ball is access. And there's real serious problems with access, and particularly in rural communities and underserved communities and yada, yada, yada. And we have to get more flexible on how do we deal with the access issue. Let's not keep our eye off that ball. And that's from a policy standpoint and from a plan management standpoint. But let's remember, let's put the patient and the employee and their family in the middle on this, right? This is not about trying to satisfy regulators and this and that. It's about people that aren't getting the services they need. And if we need to make policy corrections, let's make the goddamn policy corrections. And this idea that people want to get rich by kind of preserving these artificial boundaries based on state lines or whatever, enough of that. Let's start putting the people in the middle.
Let me ask a question also maybe for James or Amy. Can an employer set up an on-site mental health clinic? I mean, is that done? Is that a thing?
Actually, so, what used to be basically a nurse in a closet who would treat people who get injured on the job has really grown into very comprehensive on-site medical centers for employees. And so for my companies, it's mostly companies that have a lot of people in one given place. They will contract with a group like Premise or One Medical to run these sites. And they are increasingly becoming the medical home for the people who work there and sometimes for their families too. And they are doing mental and behavioral health. There are some challenges there. One of the challenges is that service, like if you're going to have a medical center on site, you want people to use it, right? Because it's going to be a better value than going off site. But to steer people to it is impossible if they're on a high deductible health plan, right? So if somebody's on the PPO, you could say you go to the on-site center, it's free. But if they're on the HDHP, they got to pay the fair market value for the visit until they've paid through their deductible. So you've effectively lost the ability to steer people there. So there are some problems with it, but definitely that is a big part, we think, of the solution.
I could not agree more with James. I'm sorry, Michael, you were going to.
No, go ahead.
Go ahead, Amy.
I cannot agree more. I really think that in the last couple of years, the on-site clinic has become a very popular way to deliver healthcare on-site, conveniently to employees and
All right, so we're losing Amy's voice again, but I wanted to also mention, James, you brought up the high deductible issue. And I know that's also been something you've been advocating around, is some exemptions around what can and cannot be treated as an expense under the deductible, and perhaps being able to waive those costs of on-site clinics, I know has been an issue that we're really advocating for as well. So we have 3 minutes. I want to give the last word to Michael because he's very good at the last word. What is this just an overwhelming battle for employers that they're never going to win, or is there an end in sight?
Well, if you define it as parity, I actually am very pessimistic we're ever going to be at the end game here. It's such a complex issue. Every time you improve something on the medical side, did you do the same thing on the mental health side? And you can have silos and organizations. Let's keep our eye on the access issue. We talked about on-site clinics, we talked about telehealth, we talked about getting people in network, paying fairly, all those things. Just keep your eye on the access issue. If access gets solved, the parity stuff will go to the back seat. I'm guarantee you, it's all about access. And don't take the pressure off the plans. And if what they're explaining as solving the issue has not solved it in your mind, then keep the pressure on the plans until they solve the problem. But I do want to be open-minded on how to solve the problem. I think we have to view telehealth as part of the solution. I think we have to integrate behavioral health into primary care, and that includes on-site and near-site clinics. We have to move that agenda together and stay united on that front. We will try to defend the parity police because I think it's just causing consternation that's getting us off the ball of access. Let's focus on access and bring that home. That's what the fiduciary role is ultimately about. It's about your employees and their families. And let's—
all right, access is the word then. But I will add one word to that: quality too. And I think James brought this
I would have
up.
said it too.
That's good. We have to look at quality, and we're nowhere on the really understanding how to measure and report on quality. So that's next. And I have to bring my leapfrog hat into that. We actually have to do better on monitoring quality. So I want to thank our guests, Amy Gordon, James Gelfand, and Michael Thompson, for excellent presentation and really a great conversation around this incredibly important issue. And I want to thank all of you for attending this webinar. Leapfrog is very pleased to host it. We hope that it's useful to employers. We have posted in the chat on Leapfrog's website is a toolkit. You go to our website, go to for employers and purchasers. Click in there, you'll find all kinds of materials and information. And later on, we will post the recording of today's discussion. Next, we're going to have in this series, we will be having a webinar on CAA and quality. Stay tuned. Thank you all for being part of today's discussion, and we look forward to seeing you next time. Thank you.
Thank you.
Thanks.